Hello, everyone. Good morning. My name is John Duke. It is great to be back here at the symposium and see a lot of old friends. I understand there's also 193 people I have not yet met, so I look forward to the collaborator showcase and the chance to meet with all of you. Now that I'm looking at the title of my talk, which is really about the OHDSI Research Network and a particular study that I had the privilege to lead, I have a feeling that at the end of the day, someone's going to go up to Patrick and be like, oh, so OHDSI is all about angioedema. But it's coincidence. There just seemed to be a continued theme along this. But I want to share with you a study that we did this year, and also, I think, maybe even more importantly, the broader notion of OHDSI network studies and how they're done. So an OHDSI network study, an analysis that's run across the network of databases and collaborators in OHDSI, begins always with an idea, a question that is brought up by anyone in the community. I'm sure everyone here in this room has questions that they would be interested in knowing the answer to. And what was unimaginable 5 years ago, 10 years ago certainly, but 5 years ago was, how could I just have a question that's just kind of, hey, I wonder this, would be useful for me to know the answer to something, and then be able to have that question addressed and answered by collaborators and friends around the world looking at tens of millions or even hundreds of millions of patients to help you answer that question. It's an amazing thing. It's almost an inconceivable notion now that we can do and that we're doing all the time. And I want to show you how you can take part in that as well. Because it really does begin with just an idea. And so while I was putting together this talk, I just decided my question for demonstration would be around, does aspirin cause osteoporosis? And I mostly just picked it because Google Images had some nice images. But after I put it in, I decided to just look up the literature to see. And it turns out to be a pretty open question. There's been some studies on it. Some say yes, some say no. More research is needed. But this question could be anything from, as Patrick suggested, utilization and cost to quality to which intervention improves employee health. All of those things would be the same notion of you have an idea that starts as a human question. Doesn't need to be any more technical than that. But once you have an idea in mind, you can pop over to the forums, the OHDSI Forums, and you post a question. Hey, is anybody interested in this topic? And you might say a little bit of why you want to do it, maybe introduce a little bit about what's been done before, but really can kind of float the question. You can see a nice example here by Sean Dolly, who some months back put this question in about anyone interested in looking at projects related to the opioid crisis. You can see he got a lot of responses back. People say, yeah, I'm interested. I'd like to help out. Some of these people might be interested in the question from a methodological standpoint, from a clinical standpoint, from a data standpoint, even a software standpoint. But people stand up and say, yeah, I'd be interested. And so this is the way the germ, the seed of the idea, begins to move to a study. Once you have enough, and there's no formal level, it could be one person wrote and said, yeah, I'm interested, or it could be 10 or 20, you begin working on a protocol. And we have a wiki which contains not only protocols that are in progress, that are under development, so it's safe, nobody's going to come and say that the protocol isn't right, but at the same time it's open, it's transparent, and we provide a nice little template. So the kinds of things that someone might want to know, what's the rationale, what's the background, and you have a more detailed protocol as well, which I'll show an example of in a little bit. This is made so that anyone can go on, and you can go on this wiki today, you could go on it right now and start putting in your idea and begin working through it as a protocol in progress. So once you have a protocol, and once you've kind of got that first wing in, you begin putting together code. And when I say you, it's really we. It's really you and your many colleagues in OHDSI who have all kinds of different skill sets, some of whom are really good at writing things like this. So folks, I often work with Martijn and Shumi and Mark Suchard. There's many others as well who've come together and helped put together the code. Oftentimes, it's taking code It's taking methods and libraries that we already have and simply modifying them to match the question at hand. So while this is not something that I might wake up and just start writing up myself, by having that process of building through the forums, of explaining your rationale and your goals, you have people who say, sure, yeah, we'd help you, we'd love to help you put together that code. And then we test the code at a couple sites, make sure it works, and when it's good and ready and feels baked, it moves into the GitHub repository for the final code. This is the code that's going to be pushed out for this study. And when that happens, you post back to the forums and say, we're ready to go, and you begin running this at different sites. And again, this is individuals with the many, I think Patrick mentioned 84 institutions, give or take. Any of those individuals with an OMOP CDM can simply go to GitHub, pull those data, and run it. And the instructions and so forth are all part of that repository. And thanks to the really nice work from those who developed the core modules, as mentioned before, the methods folks, et cetera, it produces some really terrific results that can go directly in to publications. It produces graphs and table ones and Kaplan-Meier curves and propensity score matching that's well described and explained. So the quality of the results come back, but also the raw data is made available and it can be shared back to the study coordinator. And Patrick alluded to Arachne, which is a new tool and a new capability to even streamline this process further. But the core is that you, with your idea, are now able to begin pulling together these data that are coming in and work towards the next step, which is drafting a manuscript. Now, it could be, as George showed us this morning, hey, I ran these studies at a number of sites, and I put together a website because the information is appropriate for that, and you can put it out there. You can make APIs and other ways that people can access. Or we often certainly encourage publishing in the literature. And so you come together and you put the study as a group collective effort, and then put it out in the world. You begin to disseminate it, and that may be disseminated through the article on this nice New England Journal font, or at a presentation, at a conference, etc. And so that's how network studies work. There is no magic gatekeeper. As Patrick said, people who are interested in collaborating can collaborate. And one of the best ways to have network studies done is to be an active collaborator yourself. But that's essentially how this works, and that's how all you really need is a great idea to get started. And so I wanted to talk a little bit about an idea that I had with a bit of help from my friends, both my friends here in OHDSI as well as the FDA, which publishes routinely a set of potential serious events that they're tracking. So perhaps something that's not yet on the label, something that is not yet being mitigated, but they're interested in more evidence about it. And they publish this, I hope, in part, and I believe in part, because they want to get feedback from the community and understand not only what they're looking at, but what others are thinking about that problem. And so we saw this, and this was around spring of 2016, when I kind of came across this and said, this would be an interesting question for a network study for a couple different reasons. But first, let me just tell you about the two actors in this story. So the first is something called levetiracetam. Its brand name is Keppra. It's a AED, or an anti-epileptic drug. You can see here, I know it's small, but just there's different classes of AEDs, a lot of choices of AEDs. It's very challenging, in fact, for neurologists to find the right treatment for epilepsy that works. Levetiracetam, or Keppra, is actually an extremely popular first-line treatment. It's the most commonly prescribed first-line treatment for epilepsy, and so it's used a lot. So I thought, well, this is probably an important question to look at because, as we understand, it's a medicine that's used a lot. It's not an esoteric question about an esoteric drug. It's a very commonly used drug, and it's an important question about that. So angioedema. I think you guys may have learned quite a bit about angioedema this morning from a conceptual standpoint, but you might not have a real idea of what angioedema looks like. So let me show you what angioedema is. It's a massive swelling of the face and lips It can occur in hereditary forms or in drug-induced forms. It's hard to really appreciate the significance of this until you see the individual after the resolution of her angioedema. So it is truly stunning, just physiologically, that that degree of swelling can occur, and that degree of distortion can occur as a result of a drug side effect, which is why there is so much care taken in being mindful of what is the risk, what kind of medications might cause this. As noted, the incidence is relatively low, relatively rare. There's a range, which George has already described in some detail for ACE inhibitors, and the range of maybe 1 in 1,000 to 7 in 1,000. But the main thing is it's rare enough that it's really a perfect question for a network study, where we really want to look at a lot of patients. We want to look at a number of different sites. And so what we did was spring into action. As OHDSI, I had I sent out a little missive, like a little message in a bottle. Is anybody interested in kind of helping out answer this question? And to my great and pleasant surprise, a number of people said, yes, we will do it. So the OHDSI underdog says, we're going to get going. And we began working on a protocol. And it was all done transparently. People could go and see the revisions and the iterations and the changes of the protocol as it went along. And then we published out this sort of formal, here's the description of what we're trying to do, why we're trying to do it, the collaborators who've said they'd step forward and do it, the full detailed protocol, and then when we want to launch the study and when we'd like to have your results sent back by. The code was developed using the OHDSI cohort method package, tested at a couple sites, and posted on GitHub just as we described in general. So let's talk about what we actually did here. So the study was a retrospective new user cohort design study. The patients in our treatment group were patients who were exposed to levetiracetam and had a prior diagnosis of seizure, and the control group were patients who'd been exposed to phenytoin with a prior diagnosis of seizure. We selected phenytoin as a control because it's a common first-line anti-seizure drug. It was number 3 on that list that you saw before. It's had no labeled warning for angioedema after 60 years on the market. Proportional reporting ratio of less than 1 for phenytoin and angioedema in FAERS, in the adverse event reporting system. So it seemed to be, the numbers say after 60 years, angioedema hasn't been raised as a real concern with phenytoin, so we chose it as our control. The outcome was a diagnosis of angioedema during the time at risk. So we had 2 kind of versions. One was per protocol when the patient was taking the drug with maybe a little window, and then intent to treat was from when they took the drug all the way through the end of their observation period. I'm not going to click those hyperlinks, but what they are the actual codes and concept sets that we used to define seizure disorder and to define angioedema. So in prior years, we've shown that when we do OHDSI studies, it's not patients with seizure disorder and you let it go at that. We provide this very specific code sets that are used, the time windows that are used, and even the sort of object computable description of that phenotype. So for this study, we of course have those details as well. We excluded patients who had less than 6 months of prior exposure or had a previous diagnosis of angioedema. In terms of the approach from a statistical perspective, propensity score matched treatment and comparator groups were created using variable ratio matching. We used Cox proportional hazard models to assess the hazard ratios. And we also used negative controls, which for those of you who are here at last year's symposium are familiar with the idea that you look at non-related events. So you look at these drugs do not cause these particular outcomes, so you can calibrate your data set, in this case for looking at angioedema, so that we can adjust for some of the variations across data sets. And if there was low heterogeneity between databases, we'd perform a meta-analysis. We set a nominal type 1 error rate of 5%, did not adjust for multiple testing. So that was kind of the statistical design. And we announced the study and said, okay, we're ready to go. Here's the code. Let's get to it. And I was very delighted to see 50 people went and clicked on the protocol from here. and said, let's take a look. 25 people viewed the code, and 7 sites ran the code across 10 databases, 5 claims and 5 EHR databases. And in total, we had on the per protocol set about 60,000 LEV users matched with 75,000 phenytoin users for about 11 million follow-up days each. With the intent to treat, it's a bit more, about 75,000 with 95,000 phenytoin users for obviously a much longer number of treatment days because it goes through the period of observation, about 80 million and 96 million. So big numbers to look at this very large or this very rare event. And what you can see here, and I hope you can read this, but I'll kind of describe. So there's not that many events. In total, for the per protocol, there's only about 50 events looking across all of those 11 million person days of treatment. And what we found in the calibrated, and in fact also the uncalibrated, but the calibrated hazard ratios is there wasn't evidence of a significant increase in angioedema with levetiracetam compared with phenytoin. We did do a meta-analysis, and again, you can see at the bottom a 0.72 hazard ratio. Thank you to the very, very extensively designed cohort method tools. They automatically created these Kaplan-Meier curves for me. You can see, again, the overlap. You can see the range and confidence interval, and there's not a lot going on there. The intent to treat showed, to my surprise, a little bit of a different finding. You can see we had more events for exactly the reason that George just described. We're looking not just at the time they were on the medicines, but further out. And we did see more events, and again, over the course of more days. And for a couple of the databases, we had a finding of actually a slightly lower rate of angioedema in levetiracetam than in our control, which was phenytoin. Obviously not what we were expecting or looking for. The summary results, the meta-analysis, was 0.64 relative with a confidence interval that's below 1. So this was something of a surprise, and I think raised some interesting questions to share. But what you can see here is the Kaplan-Meier curves that were produced, and you can see some separation actually, certainly in the lower left-hand corner, up between the treatment and the comparator drugs. And I will say that I took a moment, I said, boy, did I pick a bad comparator drug? I went back, I looked at phenytoin, I looked at the data, I looked at the literature, I looked at the labels, I looked at the adverse event reporting system information, and nothing to suggest an association with angioedema, but it does raise a couple interesting questions. I would say the overall findings from our study is that there's no evidence that levetiracetam or Keppra increased risk compared with phenytoin, and those results were consistent across both claims and EHR data sets. But perhaps further analysis across all anti-epileptic drugs is warranted. It's certainly possible that a medication that was approved 60 years ago may not get the same type of evaluation and scrutiny, perhaps now as medications that are more newly approved. But I think the core idea is to look at this risk across all anti-epileptic drugs and frankly across all drugs, which is something that Martijn demonstrated how could be done at scale in his presentation last year. So we submitted this paper to a journal called Epilepsia. It's very possible and very likely that not many of you in here or any of you in here read Epilepsia. It is a clinical journal for epilepsy. It's probably the top clinical journal for epilepsy. Its impact factor is around 4.7, and it is designed for clinicians. And we submitted it specifically because we didn't want the story just to be, hey, it's a method story, it's a drug safety and pharmacoepi story, but it's a clinical story. It's designed to help people who are making decisions about the treatment of patients every day and trying to select the right medications. And we're really happy with the responses that we got. We got a very quick turnaround in terms of the feedback, and they said the study was well designed, provides new insight that should be of interest to clinicians and regulators, which was great to see. And another reviewer said this is an important contribution to improve pharmacovigilance. So the way that we approached it, the scale that we approached it, the methods that we used were very well received, and it was very quickly turned around with minimal changes and published this past July in Epilepsia. And one of my favorite parts about this whole paper is, as it comes out, all the members of the OHDSI community that contributed to this, there were so many people that they had to use these crazy like icons to notate everyone. So like Patrick got like a Prince symbol, and you know, they go to like these weird paragraph forms and hashtags and stuff like that. And so my dream is one day we have so many OHDSI collaborators on our network studies that they start using emoji and things like that because they just run out. And so, you know, Mark Suchard would probably be a senior author, would have like a poop emoji, and that would be Mark's representation. So it's exciting to see, and I just, again, want to emphasize the fact that all of it just begins with an idea, with a question, with sending out a missive of saying, hey, who else is interested? And then it ends up being able to create evidence that can help clinicians, help other decision makers and policy makers and researchers with their work. And that really is what OHDSI's mission, as Patrick described, is all about. So thank you all very much for your time.